Okay, can you hear me, guys?
Yes.
Okay, so let's continue with interventions. So the interventions are summarized here in page 937. This is under the stroke section. These are best practicing for managing increasing ICP. So although this says stroke, but this will also apply in traumatic brain injury. So we talked about head of the bed elevation, which is again 30 to 45 degrees. We maintain good oxygen. So we have to monitor ABGs here to make sure our PaO2 is between 80 and 100. So the oxygen delivery here will depend on and how do we meet it, meaning what is the patient's need. If we need to intubate it, so let's say the patient's ICP is increasing, so therefore we can't maintain oxygenation anymore because the respiratory rate is now slowing down because of brain herniation, then we have to intubate. So here's your head positioning. Then here, avoid these again. Remember that the patient will be intubated here in most cases. So therefore, do we need to suction the patient when they're intubated now?
Yes, we do.
All right. And what is now the effect of suctioning on the patient, specifically on ICP?
Increases ICP.
All right. So therefore, since we know that suctioning, which is necessary in any patient with an artificial airway, how do we keep the damage caused by suctioning on ICP to a minimum?
Hyperoxygenation.
All right, so make sure you hyperoxygenate before and after suctioning. And of course, the frequency of your suctioning should only be as needed. Here's another thing, avoid clustering nursing procedures. I know you're trying to save time by doing everything all at once, but that's not really advisable. You need to give the patient rest, so avoid too much stimulation at one time because that will increase ICP. So here's the suctioning, hyperoxygenation. Here, maintain a quiet environment, avoid too much stimulation, and of course, watch the patient for hemodynamic status. All right, so let's go back to ICP. Now let's go to the surgical interventions now. So if all else fails, then the patient now, no matter what we did, the best practice earlier, we gave mannitol, we did positioning, we cannot lower the patient's ICP, then surgery will have to be necessary. Now the surgery here is, and we already discussed this chart, right, earlier? The surgery is under brain tumor. Don't ask me why they put it there. Probably because that's one of the interventions for a brain tumor, but they clustered everything because either whether or not the surgery was for a brain tumor or to decrease ICP, it's still brain surgery. Right here, page 952. All right. Pre-op will be the same as any other patient who is undergoing surgery, so none of that. Our focus is on post-op care. All right, so after brain surgery, just like what we did in hypophysectomy in chapter 62, we perform neurologic assessments every 50 and vital signs every 15 to 30 minutes for the first 24 to 6 hours. Please read the rest of this action alert. Again, this is how many times now that we saw this statement? Probably 4 or 5 times already. how you manage the patient post-op is will include, of course, watching for complications. Remember the cause of SIADH in chapter 62? What was one of those causes again that will lead to the development of SIADH?
Tumors.
Or brain trauma, right? Brain trauma or brain surgery. So here is SIADH. So you need to monitor the patient for the development of that complication. Again, the patient is immobilized here, so also watch them for VTE. Now, as far as post-op care, it really depends on where is the surgical site. So if the surgery involves supratentorial, meaning this is now above the first half of the brain, that's supratentorium, post-op positioning will be elevating the head of the bed. However, if it is below the lower half of the brain, which is now called infratentorial, which now involves brainstem surgery, which is more common because especially if there is brain herniation after severe TBI, the position is now flat with head of the bed no higher than 10 degrees. You can still log roll the patient. You can put them side lying. However, the dressing in both, because there will be a drain, usually we use a hemovac or JP, the amount of drainage should be monitored. So thank you for reading, Mr. Is Mr. Zhang here?
Yes, I am.
Okay.
A small or moderate amount of drainage is suspected. Some patient may have a hemovac or Jackson pack drainage in place for 24 to 72 hours after surgery.
Okay, and then how about the amount, sir? What is the expected amount?
Measure the drainage every 8 hours and record the amount and color. A typical amount of drainage is 30 to 50 ml every 8 hours.
Thank you, sir.
Welcome.
Ms. Mano, can you read it, please?
After craniotomy, monitor the patient's dressing for excessive amounts of drainage. Report a saturated head dressing or drainage greater than 50 ml every 8 hours. Immediately to the surgeons and monitor frequently for signs of increasing ICP.
Okay, because what is the implication if the head dressing is saturated or the drainage in the hemovac or the JP is greater than 50 ml per hour? I mean, for over 8 hours.
Does that mean ICP is still increasing?
Okay, because that could cause potential increased ICP again. And then the whole time, because not on top of the SIADH that may develop, the patient also, this is common among head injury patients. We don't really know why, but they experience what's called a salt wasting syndrome. The patient experiences hyponatremia, which is not good because what will happen to the edema, cerebral edema, if you have hyponatremia? You have low sodium levels in the blood. So what will happen to osmosis?
So the water would come out of the cells in the brain and it would increase ICP.
All right, so it will actually cause, that's correct, it will cause cerebral edema to worsen. So both you have SIADH plus the salt wasting syndrome will both cause cerebral edema and exacerbate ICP, increased ICP. So you monitor that. Once the patient is already awake, they will be given salt tablets, about 1 gram usually 2 or 3 times a day. At the same time, the patient will also be, remember, one of the causes of diabetes insipidus is also brain trauma. So here you have either SIADH or diabetes insipidus. Watch the patient for both. Just remember though that since diabetes insipidus is now the opposite, so now having said the patient will be dehydrated, blood pressure will drop, it will decrease CPP because your ICP remains high, but then your blood pressure or your mean arterial pressure drops. And this should be the last part. No, second to the last part for TBI. For patient undergoing surgery, any surgery, there are routine drugs to be given. This will include antibiotics, which is done prophylactically. Thank you for reading this highlighted section, Ms. Brittany. Is Brittany here? Okay, let's have Ms. Caldwell. Ms. Kayla? About Mr. Espinosa.
Yeah. Drugs routinely given after surgery include anti-epileptic drugs, histamine blockers, or proton pump inhibitors for stress ulcer prophylaxis, and glucocorticoids such as dexamethasone to reduce cerebral edema. Give acetaminophen for fever or mild pain. Antibiotics are typically prescribed to prevent infection for several days after surgery.
All right, thank you, sir. The drug used for this purpose is levetiracetam or Keppra. Has any one of you ever gone to 6 West in Bellevue for clinical? Anyway, that's the TBI unit for Bellevue. It's not the acute unit. It will be, I think, 6 North is the acute unit, and then 6 West is the, if I'm not mistaken, the rehab floor. So they continue the anti-epileptic drugs there because there is still some chance that the ICP increases, and one of the consequences of increased ICP is, of course, a seizure, which again will make the ICP worse if they do develop a seizure. The other drugs like H2 receptor blockers or PPIs will obviously, because of GI prophylaxis for stress ulcers, because these patients again are bedbound. Steroids will help with the cerebral edema, but only dexamethasone. We don't use any other steroid. No prednisone, no methylprednisolone, only dexamethasone. You'll see this not only in TBI, but in stroke, but also in brain tumors. Okay, patients with all these conditions receive dexamethasone. Tylenol only for pain, mild pain that is, and for fever. And then this antibiotic is usually prescribed both topically and also IV. But the IV one will only be if the patient has surgery, which the patient has in this case. Before I go to IVC for monitoring the ICP, have you ever heard of marsupialization?
No.
Okay, what is a marsupial?
It's an
What
animal,
animal?
like koala.
Like a koala, yeah.
Okay, so like kangaroos, right? Right. So kangaroos have a pouch, right? So they put their baby in the pouch. So the one of the surgeries they'll use is called a marsupialization. This is one of the emergency surgeries. It's like craniotomy, but the purpose though is only to relieve pressure. So what they'll do is open your scalp, drill out a piece of your skull, close the scalp incision, and then put that skull in your abdomen. Just keep it there in the abdomen because we will put it back later when the acute episode is over. So this procedure is done only to relieve ICP. It's an emergency procedure when all of the other interventions we did, the positioning, the mannitol, oxygenation, the phenobarbital coma is not working. So we will have, the doctor will opt for relieving the pressure. So this is the equivalent to fasciotomy in compartment syndrome. So since we can't obviously do that, all we can do is just relieve the pressure by removing a piece of the skull, allowing cerebral perfusion to restore cerebral perfusion, decreasing ICP. Okay, so the skull will be placed in the patient's abdomen, just like a marsupial, for reversal later. So while it's in the abdomen, then of course that will keep the skull viable, so the bone won't deteriorate, rather than us freezing it somewhere. So it's better if we keep it in the abdomen. It's not in the stomach, okay? It's just in the abdominal wall, because it's your own tissue, so it will grow vessels, okay? It will continue to receive perfusion. I have a question here. That procedure is not, yeah, it's not in the book. It's not mentioned here.
Professor, the skull just floats in the abdomen cavity. It doesn't. Is it attached to the wall of something?
No, we just yeah, of course we open the abdomen and but not into the peritoneum. Okay, just on the abdominal wall. So right under the skin, we'll keep the skull there. And you can actually feel it when you palpate the patient's abdomen. You'll feel the piece of the skull there. So it's kept there for viability purposes. Again, the purpose is to keep the skull, the piece of the skull, alive. Again, because it's your own tissue, it will receive blood supply.
Professor, are you familiar with a procedure just like that, but they put sheepskin around the skull instead?
No.
Not sheepskin, but it's like sheep tissue, something of the sort.
I'm not familiar with that.
Yeah, I had that same exact procedure, except they didn't put the skull inside my abdomen. They just replaced it with the sheep tissue, something of the sort.
Oh, okay. So what did they do? They just threw away the skull?
Well, yeah, they threw it away. Basically, it was like I had the cerebellum herniating out of the foramen magnum. The condition was, it's called Chiari malformation. So with that, they just had to remove part of the skull. So like the foramen magnum itself looks humongous. So they just put like sheep tissue.
Oh, okay. Yeah. You're one of the rare people who have that. We're glad you're here.
Thank you.
All right. Another here is, we never really discussed how the ICP is being monitored. All right, there are several ways to do it. The most popular and efficient way is to put a IVC. That stands for intraventricular catheter. I don't remember how they find the spot, but I know they have landmarks, particularly your eye, your forehead, and I think it's the ear. So they make an angle. I forgot what that angle is called, but anyway, so they clip your hair off your skull and then drill a hole through your scalp into the skull. So now they have a hole. They insert a catheter inside into the ventricle. That's why it's called a intraventricular catheter. Because the procedure is invasive, the number one problem there is infection. So we put a bacitracin ointment, an antibiotic ointment, around the insertion site the whole time. But because these patients may go 1-2 weeks with this catheter in there, eventually the hair will grow. So you need to make sure you regularly clip the hair to keep the site as clean as possible. But this is almost close to impossible to do. So this is why we routinely put that topical antibiotic around there to decrease the chances of infection. The benefit of using an IVC compared to a screw or a bolt, for instance, which are also used, is it serves two purposes. Not only are you able to monitor intracranial pressure, but you can also decrease it by draining CSF. So this thing will be attached to a transducer plus also to a another drainage system in order for you to remove CSF. So the doctor will give you an order. So let's say you notice ICPs rising, doctor will tell you, okay, drain this much CSF from the IVC. Okay, so it serves two functions. So it's that's why it's widely used over the other methods. And yeah, the rest of these are rehab, which is lifelong. As I mentioned to you earlier, that floor on Bellevue, patients come in there pretty much like a newborn baby. They can't hold their head up. They can't get out of bed. They can't feed themselves. They can't talk. They can't interact with you. And then 2 weeks later, if you don't see the patient for 2 weeks, you come back another 2 weeks, they're a different person. Now they can transfer, they're learning to talk, they can feed themselves, they can walk. All right. Amazing what physical therapy, occupational therapy, speech therapy can do to these patients. Of course, this would be a lifelong recovery for them, especially if they survived severe traumatic brain injury. But they're the lucky ones because most people do not survive severe traumatic brain injury. Any questions?